We have a fairly short formal agenda today, and once the formal agenda is completed, there will be we'll go into a private session, and there will be a workshop looking at the future operation of the Southwark Partnership Board as a result of changes to the health service. Shall we just go around and introduce ourselves? Would that be useful? It's always a nice thing to do anyway, isn't it? So I'm Peter John, I'm leader of the council, and I chair the Health and Wellbeing Board. I'll go this way.
Helen Kelly, Chief Executive of the Council.
Everton Roberts, clerk for the meeting.
Councillor David Noakes, an Opposition Health spokesperson.
Good afternoon, I'm Councillor Jasmine Ali, and I'm a Cabinet Member for Children's Schools and Adult Care.
Councillor Evelyn Okoto, Cabinet Member for Community Safety and Public Health, and Chair. I need to leave at 5:30.
Cassie Buchanan, I'm the head teacher of Charles Dickens Primary School. I also lead a research school and a Teaching School Alliance, and I represent Southwark Schools.
Good afternoon, I'm David Quirk-Thornton, the Strategic Director for Children and Adults here at Southwark.
Hello, I'm Vicky Scott. I'm the Chief Operating Officer for South East London Integrated Care System.
Hello, Angela Dorr, Director Integrated Care from Guy's and St Thomas's.
Heather Gilmore, Deputy Director of Strategy for King's College Hospital, here for Clive K.
I'm David Bradley, I'm Chief Executive South London the Maudsley NHS Trust.
Catherine Negus, Manager at Healthwatch Southwark. I'm told Deborah's on her way.
Andrew Blands, I'm the Integrated Care System Lead for South East London. I'm the Accountable Officer for the 6 CCGs in South East London, which I think you're aware I have to do with 5.
Ross Graves, Managing Director, Southwark CCG.
Kevin Fenton, Strategic Director of Place and Wellbeing and Director of Public Health.
And soon to be something really, really important for all of London. Yeah. So we give our congratulations to Chris Fenton on his appointment announced last week as Regional Public Health Director.
Correct. For London.
For London?
Yeah.
Yeah. Amazing.
And, Health Advisor to there.
Health Advisor to there. Fantastic. Fantastic. Okay. Well, as Heather said, we've had apologies from Clive K. I've had apologies for lateness from John T. Heversedge. And we need to confirm voting members, so indicate if you are a voting member. Thank you very much indeed. Thank you. Are there any interest or dispensations which anybody needs to declare at this time? Okay. Otherwise, we move on to the minutes of the last meeting, which was on the 18th of November, which appear at pages 1 to 5 of the board papers. Can we agree those minutes, please? Thank you very much indeed. Then we move to the only substantive item on the papers, which is an update on the integrated care system development and on CCG system reforms across South East London and Southwark. Ross and Andrew, or is it Andrew and Ross? You're going to introduce this.
Definitely a double act, Chair, and I will introduce it certainly and go through some of the slides if it's helpful. I think we've got in the papers here 2 separate items. They are related but different, and I think important to say that because CCGs, be they merged or not merged, are sovereign bodies with responsibilities and accountability under statute for health service commissioning, in this case for this borough. Integrated care systems are partnerships to sovereign bodies, so an absolute link, but would like to be clear and careful about the distinction when we're discussing them. In terms of the integrated care system, there's some update around national policy, but just before getting there, it is true that at this point in time we introduce ourselves as South East London Integrated Care System, but in truth the full title for that would be South East London Integrated Care System Wave 3. Because we are part of a national set of waves where essentially we are as much living the policy as developing it with national colleagues. As it turns out, some of those national colleagues are closer to home than they used to be, and part of the slide, page 9 in your pack and page 10, really pushes forward work that Amanda Pritchard, in her new role as the Chief Operating Officer for NHS England and Improvement, has been publishing just ahead of Christmas. However, just before delving into sort of policy for the nation, I think it's just important to say we have been working at this for some time, as colleagues will be aware. And when you strip away any of the fancy titles or anything else, we were essentially trying to instill two changes, I think. Firstly, that we would, as a health service, but equally looking to our partners, as we often do around this table, seek to focus in on populations and incentivise and reward the system for what they do for population outcome and the individuals within those populations, as opposed to some of the things that we might have done in the past, be it on tariff-based systems or otherwise, that seemed to reward the institution for what it did for the people that it saw, and most often what it did for people it saw when they'd fallen ill, as opposed to rewarding people for perhaps helping people stay healthier. And secondly, that we would take collective responsibility for outcomes, as opposed to a more transactional style of commissioning that the internal market's embodied, so providers and commissioners interacting through contracts, and I think we've agreed that both of those changes are welcome. To the national work, in November a series of papers were issued that have actually proposed a number of changes that the national operating guidance that was released at the very end of last week just simply confirmed are coming into place. They talk about integrated care systems existing in every part of England by April 2021, but they go further to unpack what integrated care systems might do. And so the roles and responsibilities, I won't read out the slide, it's not helpful for me to do so, but essentially, from my point of view, retain one role and add another. So the retention is that we'll be planning and coordinating system transformation, so how we collaborate to do new and different things. But equally adding in that second role, which is to say if we are to really have responsibility for how our system operates, we must see that as in some way reviewing and owning collectively the system's performance, be that in quality and safety terms, how long people wait if that's how you choose to define performance, and equally the financial health and sustainability of the system. And in all of those aspects we have challenges. Helpfully and really welcome from my point of view, that national articulation does then talk about work with local government, but particularly talks about the wider determinants of health, which gets you into an interesting conversation that again we've had around this table: housing, education, economic development. How do all of those things contribute to well-being, as opposed to what happens when you fall ill? Unfortunately, or just a reality, this does describe national policy, and it therefore implies that an ICS might look the same in Dorset or Devon as it does in South East London. And whilst that would be neat and a good way to progress things on paper, the complexity of our partnership, but also the way in which populations identify and how we understand and work with them is very different, as you'd appreciate. Safe to say, an ICS in South East London or any part of London is upwards of 15 partners seeking to work together just on the statutory bodies. And then I think if we would add in our colleagues in primary care or in the voluntary sector, we would very quickly get into a very large group of partners. And put simply, for other parts of the country, that is different. So we really have to take seriously that population focus, and particularly in our instance, how that plays out in each borough. It may be worthy of note, by way of update or otherwise, that within that, leadership and governance has been more specified than it previously was. Particularly talks about each ICS having a non-executive chair, and what we record here is that actually yesterday was the start date for the non-executive chair for this part of the world, Richard Douglas, who many of you may know, and if you don't know, Richard is sort of long-standing Department of Health and was at one point the nation's Director of Finance for the Department of Health, and has joined us here. It also records the continuing need for an ICS leader, and conflicts acknowledged. It records that I'm currently that ICS leader, but is also at a time where the responsibilities for being such a thing are changing. My statutory role as a CCG accountable officer, that hasn't changed. This is more of an evolving piece, so I I'm convening the system to understand my future as much as yours. So that's the first slide. The second one, I guess, is...
Andrew, just to kind of interject there, I know that you wrote to me about Richard's appointment last week, I think, because there had been some disquiet amongst some of the borough leaders expressed to you about Richard's emergence. Do you want to just talk through what kind of how it took place, what the involvement of local government as key partners was in that, if any?
Sure. So, although the timing of the appointment and indeed the panels for each part of London was encouraged to be consistent, so there were local input into each of the panels and consistent input into each of the 5 London panels, there was an acknowledgement of difference. So effectively for 3 parts of London, the issue as it pertained was that we had officer representation planned for the interviews, and for 2 parts of London there was a preference for leader for leader involvement in the interview panels. We are one of the 3 areas that had officer involvement, some sort of officer involvement, and I guess the level of disquiet was the level of dialogue that led to that decision. So, in all honesty, I felt that we had got to a good place in terms of agreeing who would be involved across that, but it seems that that was not necessarily clear or good enough. And that is as honest and direct as I can be about it.
Who's involved from Southwark's perspective in terms of...
So we were asked for representation across sections, so particularly from Southwark we had John Heritage representing Southwark.
Okay.
So Andrew Travers was the representative. Andrew Travers had bereavement the day before, and I think that is probably, I believe he tried to find one of his number to replace him, but was unable to. Andrew Travers being the Chief Executive of Lambeth Council. So the slide then next there then outlines again some national stipulation, although in truth the idea of an ICS partnership board is something that has been in play for some time in South East London, but where we have had a partnership board which has sought the involvement across our full partnership, it has been for the purposes of transformation exercises or particularly looking at bespoke pieces of work. Well, the partnership board here is a dialogue at the moment, an invitation to derive an ICS partnership board, which, to be clear, it does exist in name only because our current partnership arrangements would not satisfy this. How will we bring together partners from across South East London such that we could oversee some of those ICS responsibilities? That is further complicated in South East London or any complex parts of the country because we have a rather large number of partners, but also a commitment to take decisions in a delegated fashion as close to people as possible. As I think in the spirit of this afternoon, the ICS Partnership Board is a work in progress. We will need to find a way to bring people and colleagues together meaningfully to have a discussion at South East London, whilst accepting a huge amount of the activity that needs to go on will in actual fact be in borough-based discussions, which will involve the Health Wellbeing Board, Partnership Southwark, and indeed the borough-based board of the CCG. And I think that is part of the reason we're sat in the room. How does one get into a discussion that satisfies those various different population levels simultaneously? So that is the partnership board, and then form follows function. That partnership board will only be as good as the governance that serves it, and what would we like to design and have available to us such that the system can come together and understand performance, for want of a better word, through a population lens. At the moment, we in our silos understand how Guys and St Thomas is performing, or perhaps Slam is performing, or indeed a single CCG. So what will we put together that allows that dashboard for the population to be established? So that was the second request. We are seeking to move at pace on that, such that we're operating in that type of fashion. Nonetheless, we are on a journey, and that journey does not conclude until April 2021. Clearly, if we're able to establish a good way of working ahead of that, that's to everyone's advantage in doing that. Thereafter, I'm not sure, Chair, I'll be guided by you that slides 11 and 12 add much to our previous conversations. They essentially make the case that we should understand the activities we undertake as a partnership at the level of the individual and neighbourhood level, place, which is a national term, and we have clearly articulated that as boroughs in London and at system level. And for us, you've heard me say many, many times that South East Londoners tend to get their care in South East London, so it feels like a sensible geography to be planning some aspects of our work with residents and when they become patients. And indeed, page 12, I think I brought here at least twice, and maybe it feels like many more times than that, was the system of system diagram to say there are some things that must absolutely be organised at the level of the neighbourhood, but we can move that right up to tertiary care, where it may well be sensible to be working with colleagues in Kent and right across South London, given the portfolio of some of our institutions. And then the final one, an ICS update, was slide 13, which I guess, again, is an invitation or context for further discussion. And I think I've, broadly speaking, covered it. We have an opportunity for local government and the partners represented around this table to have differential interplay into those governance arrangements. I think quite well established arrangements through the CCG reform that every borough will have a borough-based board, that borough-based board would have delegated authority for a number of things, and so you have a direct way of being represented and taking decisions within the system. What we haven't come around yet is how does one lift that up in a sensible and productive way to South East London, given the number of partners we have. So for some parts of the system, we anticipate there will be representative ways of featuring in that governance. For others, there will be a preference for more direct involvement around decision-making tables in the spirit of a partnership that covers the entirety of South East London. There are a number of models for that, but broadly they fall to categories of representation, which implies a good level of mandate behind that representation, or direct involvement, and of course then we seek to play that out at the level of the borough and at the level of South East London. So when we're planning our partnership board, how will we make that work effectively? What is more established right across South East London, and certainly in Southwark, is that with the CCG reform, a borough-based board would have delegation for local decision making, and we're hoping that that borough-based board would interface with Partnership Southwark in this case, so you have a dialogue between commissioners and providers rather than an exchange of letters or simply relying on a transactional contractual relationship. I can pause there, Chair, but I guess the other slides perhaps just add in the CCG reform bit and perhaps helpful to look at them together. Would that be okay? So this one falls in the category of straightforward update because over the course of our merger application, we've engaged with this group particularly. Essentially, our application for merging of the 6 CCGs was submitted in September and was approved by our regulators in October. The approval only in practical terms allows us to begin implementing that single CCG. Sovereign bodies, so NHS Southwark CCG, remains until midnight of the 31st of March, and on the 1st of April, NHS South East London as a single CCG for those 6 boroughs would begin. I think there's a couple of things worthy of note, but we made a number of promises in the process of CCG merger application. The first one is that we would include within that the establishment of borough-based boards and the ability to delegate local decision-making, and in short form, we have kept that responsibility. So our application recorded that ability to delegate, and that's what will happen from the 1st of April going forward. In addition to that, we said we'd make the opportunity available, because we clearly can't compel local government partners, to join their NHS colleagues around those borough-based tables and in as far as possible make those committee and common affairs where we as a minimum discuss policy and implementation together, but it opens the door and opportunity for that to be more integrated over time. We have kept that promise. The third one was that we would have a commitment and would attend to local accountability as a sort of umbrella term. So although there's a single CCG, it will still relate to 6 health and wellbeing boards, it will still relate to 6 scrutiny arrangements, all of those things that we see as keystones of local partnership interaction remain, or be they executed in a slightly different way. And you may also recall that we were asked to reduce our management overheads by 20%. We were concerned about the capacity that would be left behind if we were to simply salami slice 20% of our workforce. We were concerned about that. So we have essentially, through our merger proposals, sought to derive that from back office efficiencies and put very simply, and I'd say this if Dr. Heritage was here and some of my colleagues. No, he is here. I'll definitely say it now he's here. We also, by virtue of having 6 governing bodies, we're running 6 governance arrangements for 6 governing bodies. So a large part of our management cost reduction is actually been derived from the rationalisation of governance at a South East London level. As a result of that, we have less governing body members remunerated from our running costs. I think slide 3 is worthy of note and very good timing, John T, and that we have been describing a governance structure and governing body that we would populate. In December, we populated all of its parts. Nominations for accountable officer and chief financial officer needs to be made to NHS England nationally, and that has been undertaken. But what's within our control has been completed. So our clinical members of the governing body and our lay members have been appointed, and I think on the 9th of January, or certainly a couple of weeks ago, they were asked to receive a nomination for and choose their chair. They did that, and John T. Heritage was CCG. In addition to that, just of note, this also introduced a new post for the CCG in South East London. That was one of Chief Nursing Officer. And I can also report, and I think you would have seen it in our communication, that Kate Marty-Baker is currently a CCG member of staff here, director here, will be the Chief Nursing Officer for South East London. So we're very pleased, clearly, to have that Southwark input into our South East London arrangements. But we are good to go in terms of governance arrangements, and that is recorded in the next slide, simply to say our statutory responsibilities are maintained, so all of our CCGs will continue to perform them until the 1st of April. In shadow form, that governing body is coming together to plan the way in which it will operate going forward. And then finally, and I will hand to Ross after slide 18, that also involved a further change that we would look at the structures that support a single CCG to make sure we do have that right balance of staff locally in each borough and equally on a consolidated basis to realise some of those efficiencies and to undertake work at the right scale. Put very simply, we employ around about 460 staff across South East London in the CCG space. We undertook a consultation that ended about 2 weeks ago with those staff to describe those new structures, and we had an enormously positive response to that in terms of numbers of responses. People had things to say about it, and as a result of that, we were able to make a management response for implementation on Friday. So the next couple of months are about making sure the right people are in post across South East London, such that we are good to go as a sovereign body on the 1st of April. My reason for handing to Ross for the last couple of slides is that within that, it also implies that we have good borough arrangements according to the commitments we've made, which bring us to the Commissioning Board and Partnership with Southwark Board.
Thanks, Andrew. So just to talk a little bit more to the local system governance, so I'm looking at pages 19 and 20 in the pack. So 20 really just describes with a diagram some of the words that are on page 19. So we have 3 really key sort of governance fora for Southwark, and indeed some of this starts to frame the workshop that we'll be getting into slightly later this afternoon. But just to call them out, so the Southwark Commissioning Board is our local borough-based board, and that will have the delegated responsibilities relating to local care, and it will also shape the delivery of wider services across South East London via the membership of the CCG governing body and also where relevant membership of the ICS board for South East London that Andrew's talked about. So the shared ambition is for the Southwark Commissioning Board to be a committee in common between the CCG and local authority, and we are, well, in the process of developing and shaping a plan for integration, which will start to look at how we can bring commissioning from both organisations together through that committee in common. The Partnership Southwark Strategic Board is our local care partnership board. So that is the other piece, the broader system board and partner board for Southwark as a borough. So again, that's bringing together a range of commissioners, providers and other stakeholders from across the system, providing strategic leadership and oversight to both the Partnership Southwark programme, but also the broader transformation of health and care across the borough. The third piece there, and that's called out on the next slide as well, is of course we have Southwark's Health and Wellbeing Board. And clearly that has a key role in setting the overall health and wellbeing strategy for our residents based on the JSNA. And I think the workshop and what we want to get into a bit later this afternoon is about the interaction between the Health and Wellbeing Board and the Strategic Partnership Board and how those two groups sort of work together in the future. Not spoiler alert, as it were. So slide 20 then sets out in a little bit more detail and in a sort of a diagram, but it also talks about some of the key priorities and work streams, both from a Partnership Southwark perspective and key commissioning programmes from a commissioning board perspective. And I think there is a key job of work for us to do as we start to stand up these arrangements, to start to look at where we can have a single conversation for the system. And I think a great example of this is some of the work that's happening in the children and young people space. So the Strategic Children and Young People's Partnership, SKIP, is very much occupying both a commissioner and provider space and gives a great foundation for a sort of a shared approach across commissioner and provider and system endeavour as a whole. And I think our ambition would be to look at how we can use that as a bit of a model for system ownership of our priorities. Other things to note is that we've also formed a clinical and professional leads advisory forum for the system, which again is early days, but we've started that linking in sort of clinical directors from NHS providers and primary care networks and the CCG, but obviously with an ambition of broadening and expanding that and bringing in broader multi-professional leadership. So I think we would be very keen to do that as soon as we can. Final page really just gives an update on where we're up to in both standing up the Southwark Commissioning Board and also the Partnership Southwark Strategic Board. So again, this kind of frames, I guess, some of what we're going to be getting into a bit later this afternoon. But just very briefly, so progress to date on the Commissioning Board side has been really supporting the sort of terms of reference, key roles, key arrangements, but also looking at some of the supporting functions, if you like, that would support a borough-based board. So we're looking at how we engage with local patients and residents, how we engage with member practices, primary care networks, and so on. And we have a seminar later this week to I've called it a dry run, but it's essentially to start to look at these emerging documents, terms of reference, etc., and sort of actively shape that together. Then turning to the Partnership Southwark Strategic Board. So I think it's important to say that we've been meeting as a Partnership Southwark leadership team for over 12 months. We have an established programme of work there focusing on shared priorities for the system. But really the next piece there is making sure that we have this broader system partnership board that is lifting up more into a space of system partnership and oversight, whereas the Partnership Southwark leadership team has been very much focused on shared milestones and shared priorities that we've agreed across these organisations and how to deliver them. And I think I'll probably leave it there, Chair.
Thank you very much indeed, Ross. Now, just on the Southwark, I've got a couple of quick questions. Southwark Commissioning Board, borough-based board, that was going to be a joint appointment of a head of that or not? Have I imagined that?
So we've essentially said that partnerships who are ready to can propose joint appointment. Partnerships that are ready to kind of propose joint appointments, those that wish to joint appointment but wish to do that at a later date can do that.
Right.
The Southwark position for 1st of April will be at a later date.
Right. And then the Partnership Southwark Strategic Board, I mean, how in any meaningful way is it different to the Health and Wellbeing Board?
So I suppose whereas the Health and Wellbeing Board is setting and overseeing an overall health and wellbeing strategy for Southwark, the Partnership Southwark Strategic Board is much more focused on the transformation of health and care. But I suppose also, I mean, I would recognise that this is up for debate, and it's something that very much we'd sort of recognise when we were shaping the agenda for the workshop that we're about to move into. So there is definitely significant strategic synergy and membership synergy between the two, but at the same time, I would say that the strategic board is a tighter focus on health and care transformation.
I mean, I think it's not to depict it in any way a trick question, Chair, but I do think that is exactly the thing to tease out. I can, for my two pence worth on it, I had anticipated Partnership Southwark, and as it's put here, a strategic board would be an agreement for those things that providers would do in response to the strategy set here, so that it would be the operationalising of the Health and Wellbeing Board strategy. So depending on the output of discussions, and I'm not at liberty to stipulate how those should look, I had imagined it as the officers of provider organisations working together around the population and the incentives that we might create in response to the Health and Wellbeing Board's strategy. Clearly, however, we're in the space of self-determination here, and if it needs to be something more or less than that, then that is a good discussion to have.
Okay. Well, I don't want to preempt our workshop, but John T, you indicated and David indicated.
No, thank you, Chair, and I do apologise for my lateness. So I think that's exactly right. Let's have exactly this conversation in the workshop. There's still, I think, a very important role for the Health and Wellbeing Board in terms of a degree of accountability here for the system that's really essential. Certainly at the moment, because we've got differential roles between the commissioning side and the Partnership Southwark side, that adds an equal level of complexity. Obviously, as we move towards arrangements where essentially we've got that system responsibility, I do think Andrew's probably right, that moves then much more into a kind of, if you like, operationalisation of the strategic commitments that the Health and Wellbeing Board makes, but we ought to tease out exactly how that would work going forward in the workshop after this.
I just wanted to just press on about the integrated care system. I just want to fully make sure I understand exactly the relationship. Are integrated care systems separate to borough-based CCGs, or are they a sort of something that just sits next to it? What's the exact relationship between the borough-based CCG and integrated care systems? And do integrated care systems always match the arrangements for CCGs? So if there's a 6-borough cluster, then that's what the ICS will be, or does it vary? Can it be different?
The sort of two straightforward answers to those questions. The CCG and Foundation Trusts or NHS Trusts remain sovereign bodies with their statutory responsibilities, and they do not change. And so, to that sense, they are distinct from an ICS. An integrated care system is not a sovereign body. It only has the decision-making powers that are invested in it by its sovereign partners. There is a stipulation on all of our NHS organisations with a commission or provider to join an ICS, and I think the wording used here, including with local government, because that is a choice. I think it's a choice that people readily come to as a positive discussion because of the wider determinants of health and wellbeing come together. But a single CCG, or indeed this CCG, is a sovereign body. An integrated care system is a partnership of sovereign bodies that has as much power as the partners invest within it. So the first one. The second one, the NHS long-term plan, which is sort of now 12 or 13 months old, essentially made the recommendation, which I think is now firmer in operating guidance, that CCGs should be at the same unit or geographical size as the ICS, and that is largely to one of the other slides here that talks populations, to say that part of system working implies that you can make commissioning decisions for populations where services may be specialised, so require a bigger scale of decision making and more local, in our case, in each borough. So the literal answer is, at this point in time, we have some STPs to become ICSs that have multiple CCGs. By the time we get to April 2021, the two will be one and the same. Yeah, okay. And it takes a lot longer. So Sustainability and Transformation Partnerships, Chair. But in essence, by April 2021, there is an ambition that CCGs be the same size so that they can have a population focus that can then be understood at its various scales.
Yeah, go on.
So does that mean eventually there will be no single CCGs? That's the vision, is it? It won't be possible to remain as a single borough CCG in the future. You'll have to cluster.
I think that's we are in London, that's a very London-focused question, I think. So for some areas of the country, they are merging CCGs so they can be at the same footprint as the local authority. So it's quite a different thing to be discussing it in London or, let's say, Manchester or otherwise than it is to discuss it in Devon, Dorset, or I always use the West Country as an example of this, but just unimaginative, I apologise. But merger with some CCGs will be to operate at the same unit as the local authority. So it happens to be the reverse in London, so we have different challenges because of the way which we start life, if you like.
Okay, Evelyn?
Just wanted some clarity. So are you saying that all STP, Strategic Transformation Partnership, will all transform into ICSs? Is that what we're saying eventually will happen?
I don't want to dance on the head of a pin, so the general answer is yes. The only thing I would say is that some Sustainability and Transformation Partnerships, or STPs, Chair, may need to discuss amongst their partnerships whether they're the right size or not. So our STP has been a population of 1.92 million population, and we have based that on the where our residents get their care from. But there are other parts of the country where the STP is currently less than 1 million. And so there needs to be some conversations in that partnership relevant to that area as to whether that is the right scale or not.
Thanks. So just a couple of questions. Firstly, on the back of Councillor Rakota's question about STPs, just want to give you an opportunity to perhaps share what learning has been taken on board by the NHS and government post STPs as we move into the new world. And also, if you could just give some reflections, please, on how we'll be looking to navigate the disparity between us. So an NHS with a 10-year long-term plan, local government with 1-year funding, and
but sometimes 30-year plans.
But sometimes 30-year plans, quite sure. And within that, again, not to preempt the discussion for later today, but if you could just spend a little bit more time, please, on the distinction between the added value of, for example, Health and Wellbeing Board and democratic accountability, and communities having a voice in an NHS changing world that is bringing together things at a much larger scale, perhaps operationally very sound, but may well feel quite distant from local communities. So just a couple of things, post-STP, what learnings been taken on board and how we're mitigating making same mistakes again or same errors again, and then moving into how we can work together and how local communities can really feel like they're represented and engaged in that process.
Okay. In an entirely apolitical statement, I would make it clear that for RICS and previously STP, it would be extremely helpful if the planning timelines for allocations, funding and expectation were the same across health and social care, and they are not, and therefore I think it makes it harder to realise the opportunities that alignment would bring. And it's not really my gift to change it, although I do welcome the fact that there is at least a hint or a heavy nod to longer term planning and return on investment decisions for the health service. I think that is a step in the right direction. I think the long-term plan itself, when it was issued the January before last, and every document I've seen before, seen since that, Simon Stevens is the NHS the Chief Executive of the NHS in England, has made clear that the health service can only take things so far, and this plan would therefore need that same level of certainty in terms of social care. So I mean, I guess that's my response there. I think there's a multitude of answers, and perhaps other colleagues may have their own view around learning or otherwise. For what it's worth, we think a couple of things. So I think in national policy terms, the articulation of STPs, where the P was a plan and then became a partnership, didn't feel very different from each other, and so I don't think in either their planning for or actual development of STPs, you could really see a clear line of sight for how members of the Health and Wellbeing Board or local government and the NHS would operate together, and part of that was around the focus, and the focus felt very health service based. Over that 2 or 3 year period, there's a very clear commitment, if not requirement, for us to simultaneously look at populations at neighbourhood level, at place or in our context borough level and at system level, and I think a recognition that can only be done hand in glove with local government. So I think there's a sort of overall macro lesson learnt there. For what it's worth, South East London put ourselves forward to pilot ICS working because we felt that there were 5 things that, even if national policy were very clear, didn't particularly work for a metropolitan environment or our own environment. So the first one is that we felt that in moving to an ICS, governance arrangements did not bring forward some of the things you mentioned actually. So the ability to hear residents' voices very clearly in what we were undertaking. We didn't feel that governance arrangements were really worth pursuing if they only related to the marginal change or transformation monies, as we call them in the health service, unless they talked to the whole. We were in actual fact wasting time, and we didn't think that governance paid due account to a genuine partnership of local government, but also some of the wider providers that we would find in the system, voluntary sector being particular. So there's one of our areas. I will race through the others, but in our position in South East London, an articulation of an STP very often stopped and did not include specialised commissioning, where in truth our providers in this patch get just shy of £1 billion worth of income that they rely upon from specialised commissioning, but we do not have a direct population-based way of interacting with that commissioning. It is undertaken elsewhere by NHS England, although with efforts to try and join that up, but not that responsibility. So that was our second. Thirdly, we felt that incentives were misaligned to the endeavour. Now, we have taken action ourselves on that by moving away from a tariff-based system that essentially rewarded you for doing more and not for the outcome that you derive, but nonetheless we put that forward. Thirdly, we didn't feel that there was enough emphasis on the responsibility of providers to work together, but equally to make that a two-way street, we felt that some commissioning activity could be better undertaken by groups of providers who are willing to focus on outcomes together, and we described that as a sort of vertical integration within boroughs to say that if we had something like Partnership Southwark, would service design be better owned by those providers seeking to deliver it? And then the last one is that we felt national articulation of STPs really spoke to a far simpler system than the one that we have. And we feel that there are real advantages, particularly in the workforce, its availability, its training and its retention, if we have South East Londoners who are able to work across partnerships of organisations, be that the South London Partnership for Mental Health, but equally between Guy's and St Thomas's, King's College Hospital and Lewisham and Greenwich Trust, and we talked in those terms about horizontal integrations. There are our 5 offerings back to the nation as to why we feel either in London or particularly in South East London, without having those learnings as part of this, we couldn't really progress. And if you don't mind, Chair, my ducking the last piece, because I think I would be as interested in other people's views. I'm not sure I have the answer. It is quite clear that our involvement of local government in London, where we have a borough-based arrangement, is easier to articulate in a borough than it is at something that is a collection of boroughs. Yet there are some things that either get funded or have greatest impact as a collection of boroughs. And so I think the discussion here today is about Southwark. There must be a discussion in a room near you soon about how does one make it easy to collaborate across the 6 local authorities of South East London and make it easy to collaborate right across London. And I think that middle tier doesn't often get huge levels of discussion. You're about to correct me and tell me it does, and I just don't recognise it, but that's the kind of debate I'm in. How does that sub-system really work, and is it legitimate? You may feel that it is not, and it's artificial, and we should have a different combination of boroughs, but I put that forward for discussion rather than saying I know the answer to.
Just remind me, Andrew, how is local government represented on the ICS, South East London ICS? Who's on it?
Put very simply, well, okay. So at this point in time,
because that's the level that we're talking about, isn't it? That's where the 6 boroughs talk about what the.
Absolutely. So at this point in time, but I have between now and if we set our objective to have a ICS Partnership Board change by the 1st of April, that is an unanswered question. Okay. I can tell you the historical answers to that question. So in 2016, the answer to that question was that Barry Quirk, no longer of these parts, essentially provided a voice of local government on a partnership programme, and we've developed that by each of our SDP programme boards having some form of officer involvement. So our community-based care programme board, for example, has a DAS involved. We've taken some other what I call necessary but insufficient steps to get greater local government involvement. So we're the only SDP/ICS in London that has a part-time DAS as part of our executive team, and we offer that out to all boroughs, and we have 2.5 days a week of the DAS from Lambeth, for example, to assist us. We have stood up a number of forums, but most notably my executive team meets every 6 weeks with all of the directors of adult social care to help us plan some of these agendas, and our most recent go at that brought in, although with less complexity in Southwark, brought in directors of children's services and directors of public health. And then in terms of our partnership boards, as it stands at the moment, acknowledging it will change, we've asked Professor Fenton to join us on behalf of Directors of Public Health, and at this point in time Fiona Connolly, who is the DAS for Lambeth, joins us on behalf of social care. They are all historical points, however, because going forward we have an opportunity to refresh that, and I can also tell you confidently, and to the leaders' discussion around the ICS chairs, each part of London has chosen to do things differently.
Okay. I mean, there is an argument for having either the leaders directly elected mayors or their nominees from each of the 6 boroughs on the ICS board.
So as I understand it, that is entirely possible. What I also very quickly get into discussions about is numbers of people and what they do and so on and so forth. But I have to say, from my perspective, the commitment and ownership of this agenda, politically or otherwise, from local government is very important to me. So it's the way in which that's best enacted.
But it kind of answers David's question about where do you get the kind of the democratic, or how do you overcome the democratic deficit at that 6 borough level potentially? I mean, you might say, well, it doesn't, unless you have every one of the 1.92 million on that board, it doesn't really work. But there is representative democracy.
I think I mean, since you raised it, Chair, and I think it's a very live discussion. I know that there are parts of the country and parts of London who intend to do that on a representative basis at a sub-regional level. There are other places that would like to have forums that are effectively a council of members that then inform a smaller executive group. There are a number of models being put forward, and I think they just try to marry up practical effectiveness with local democratic accountability, and we're all for that. It's what is the best method of doing it.
Okay, really, really interesting, and it's encouraging what you're saying, Andrew. That's the main thing. Professor Fenton.
Great. So I had two questions. The first was on engagement of local government, and which you've answered. But I did want to explore how chief execs of councils are engaged currently, and what would you envision as an effective way of doing that moving forward. And second, we've spoken a lot today about structures and governance, and relatively little about priorities. And I wondered if you could just reflect on the London vision, the emerging priorities for South East London, how those interact with the boroughs as well. Because I think there's a dynamic interplay here, and understanding what additional value this will bring to the system, I think is key.
Before you answer, I'm going to take Jasmine's question very quickly, and then
Yeah, I mean, just very quickly, I mean, just on the STPs to ICS, it feels an observation is the STPs is quite a toxic brand now, and the ICS is much more positive, so it feels like it's going to be a natural transition. I think the other point, I think really, on looking at the Southwark partnership and the systems approach, it does feel that you need more. You know, you need to be as inclusive as possible in order to get everybody's viewpoint. But then on the health and wellbeing boards, you know, which obviously we're going to have a wider discussion later, that to me feels quite important, because obviously we need to monitor and manage what's going on the ground in our respective local authorities. And I just wondered if you had any observations of what our partner councils in the new world are actually thinking, and how far they are down the road of the discussion about, you know, the status and the feel and the legitimacy of the health and wellbeing boards in the new world.
Just to take that, STPs, toxic brand or not, I think they were partial solutions to a more holistic problem. So I think, I don't know that it's the three letters having changed, it is that there's emphasis on looking at what's local partners can achieve together. And I think there was very definitely in sustainability and transformation plans quite a financial focus, and one that drew in a conversation that's felt quite internal to the health service. It's a personal reflection, but I think a number of other people, commentators, have made it. ICSs to me feel different, and I think Amanda Pritchard in a national role is making that very, very clear from the get-go. So that is welcome from my point of view. Just in terms of health and wellbeing boards, the discussions that I've been involved in the 6 boroughs across South East London, I haven't heard anybody stand down or imply a lesser importance to the health and wellbeing board. I think in some quarters, in actual fact, the opportunity to have something like the partnership Southwark arrangement gave people greater confidence that the things discussed as a partnership and committed to then had a vehicle for delivery. I can tell you now there is a live discussion going on that I think will only serve to increase, not reduce, membership between the health and wellbeing boards and local care partnerships, and that's, broadly speaking, that across our 6 boroughs, and no doubt across the 32, there are very different views about where elected members may like to play into those arrangements, what tables to be around, where to have great effect. And this is something for this partnership to discuss, not for me to stipulate, but I would just say there are different models playing out. But health and wellbeing boards, I think in my discussions have been quite welcoming of a more definitive vehicle of partnerships to deliver the things that they have set out for their places, if you like. Kevin, your first point around chief executive leadership, I mean, I don't know if I should seek a view from Eleanor or not. I have been involved in a huge number of discussions that have sought to get chief executives together on this arrangement. They've always come back down to the arrangement we currently have for the London Health and Social Care Partnership Board, which has been a representative model, which, as I said, at a point in time had been Barry Quirk, and more recently has been Andrew Travers. Whether that model has the requisite underpinnings to allow that to give a coherent and consistent voice, I think is highly differential over time and by location. So I'd be interested actually in your guys' views, and you may have a particular view about how that is best exercised. I have been nothing short of impressed at the pace with which
DPHs, but also Directors of Adult Social Care, have been willing to come together and make compromises or not, in order that we get to a consistent or appropriately differential view as how one progresses things across the geography with such a diverse population than we have. Your point around the priorities, without going through our response to the long-term plan, if I just make just a straightforward distinction between those, we had essentially talked around a huge number of efficiency and productivity priorities. We talked about what might be derived from acute-based collaboration, community-based systems, otherwise. I do genuinely think both the long-term plan nationally, but also our own intentions are to broaden that out to conversation on inequalities and prevention as the two things that we would be seeking for a felt difference in our planning and response going forward. Of course, we will need to be discerning, and it is a perennial discussion as to what is the best population level at which to undertake things. I think, Kevin, you've heard me say, and I'm sure you'll not feel conflicted by your new role coming along, but in the same way we'll need to take a decision about what is best effected above a borough level within South East London. There is that same discussion to be had at a London level. And I fully support the vision put forward by London and the priorities it espouses, but I think running through that, each of them poses a question about systems that at what level do you best affect this change. And every conversation I've come to is that every level has a contribution to make to one of those changes that is put forward there, be it childhood obesity, be it adolescent mental health. All of those areas appear to have a combination of scale at which they must make some contribution. Andrew, thank you very much indeed for answering all those questions, and I think it's helped frame the conversation that we're going to have subsequently in private session very well. We will leave you to go and enjoy your fizzy drink. What fizzy drink? It's Fizz-Free Feb, don't forget, everybody. That concludes the formal part of this Health and Wellbeing Board meeting. We'll take a 2-minute break whilst the room is rearranged. We're going to be one group, though, having this discussion, aren't we, Everton? We'll be a 2-minute comfort break and then we'll resume. So thank you very much indeed for attending today, if you're a member of the public, and we look forward to welcoming you at our next meeting.
I'm so sorry, I knocked the camera as well.